Okay, hi everybody, it's Lee and I'm going to be doing a video today on the Porter Nitronox unit for those who need a little bit of a refresher. So please bear with me because I'm by myself. I don't have anybody using the iPad as a camera. So I may actually kind of chop this up a little bit into pieces and post it separately. So the first thing is where do you get information on the Nitronox unit? And there is a policy posted on, or procedure posted on Policy Tech. It's called Nitrous Oxide Use in the Family Birthing Center Guidelines. We've also made these cheat sheets that are available at the desk, and I will make some more. So basically what these cheat sheets are, just plastic paper copies of what's in the policy with some nice color pictures to go through, lots of information. So what I would really suggest is to familiarize yourself is read the policy. I know it seems a bit onerous, but it is very procedural and there's some repetition. It'll probably give you a better idea about how you kind of want to approach it from a step-by-step perspective. So the first thing I want to talk about is I want to talk a little bit about the parts of the unit. So the unit is set up with, let me just see if I can show you. You can see that there are two blue tanks, those are your nitrous oxide, and two white tanks. That is the oxygen. Oh, there's the other one, sorry, around there. Okay, two white tanks, two blue tanks. Nitrous oxide is a heavier gas, and you don't require as much of it as you do oxygen. But what basically happens is the nitrous is in this, goes through this blue tube here, and everything is connected. You do not need to reconnect any tubings or anything, okay? The white is the oxygen tube, and these go into these, this meter here, and this is a blender. And the blended product will then come out of this gray tube and will go to the patient demand valve, and I'm going to set it up in just a minute for how it's going to look. Okay, now I know it's reading backwards for you right now because I do have the reverse on here, okay? But we can turn it around or you can look at the pictures. So that's the first thing, is you don't need to do anything else with this setup because the tubes are all attached, and we're attaching 2 tanks of nitrous oxide and 2 tanks of oxygen to each unit. So that means that on FBC there will be 2 of these units, each with 2 tanks of oxygen, 2 tanks of nitrous oxide, with extra 2 tanks of nitrous oxide and extra oxygen in that area across from the nursing station. And there is a previous video out there on how to change a tank, and I may need to refresh it, which is fine, but I've been told that it's very, very similar or exactly the same as changing the oxygen tank on our shuttle. Okay, so the other part of this is this pink tubing, and this is a scavenging tubing. So this is actually one part that's going to be disposable, so it's single patient use, and the scavenging system is at the back of the unit. I'm going to turn the unit so you can see that. The scavenging system is this piece here and this black piece, okay? And we're just setting up normal, regular, non-sterile suction tubing to the back of that. And it's come off, so let me just put it back on. And then your other end here would go into the maternal suction. So the patient suction, the red canister, and you turn it on to full. So do not use the infant suction canister, use the patient suction at the head of the bed. Okay, that's for scavenging. Now, these are kept across from the nursing station. As I said, there's 2 units. How do you know when it's ready to use? It's ready to use when there is an oxygen mask, and your oxygen mask is this, or your patient face mask rather, sorry, and an HME filter, okay, which there, it looks like that. Now this one comes with an extension tubing, and we're not gonna be using the extension tubing. I'm gonna take that piece off. This machine should have been set up with the face mask and the HME tubing already attached, but it wasn't. And I'm just having problems opening it. Hang on one second. Okay, here we go. Maybe that's a better shot of the HME filter. Just take off this tubing here, like that. And we're gonna put a face mask on. And this is also disposable, so I'm actually going to put it back in the bag when I'm done with it. So it's only gonna go together one way, which is good for those of us that are trying to put things together when we're tired. That's not gonna fit. It goes like this, okay? And then you're going to attach it to this part, which is called the demand valve. Okay, this part is not disposable. Okay, it is reusable. So that is what it's going to look like when it's ready to be used. So I told the aides, I've instructed them to keep this part in the bag so it's clean and ready to go. So this is when you know it's ready to go. So if there are pieces missing and it's across from the nursing station, just ask if it is if it's ready. Otherwise, it should be cleaned, and to clean it, we're just going to be using, I kind of look disembodied here, the hydrogen peroxide wipes to wipe down all the canisters. And the parts that get thrown away would be the HME mask and filter. So after your patients use that, you could take that off, throw it away. This pink corrugated tubing, which is scavenging tubing, and the suction tubing, the non-sterile suction tubing. You can take that off, throw it in the garbage in your patient's room, and then when you're done with it, you can just wheel the unit out into the hallway, and the aide will know to clean it and get it ready. You can use this device for patients on respiratory or any other kind of precaution, droplet precautions or any other kind of precautions. I would say that you definitely read the section on contraindications and absolute contraindications, because if you have a patient with really severely compromised respiratory status, it may not be the most appropriate modality to use, but it is okay to use for people that are on isolation. And in that case, what your responsibility is as the nurse or the midwife providing it is to make sure that you take off the HME filter and the mask, the corrugated tubing, the scavenging tubing, the suction, and throw it away in a yellow bag in the patient room. And then just take a clear plastic bag and place it over the unit and push it out in the hall. So then the aide knows that it has been in a room where there's been, a patient has been on precautions. Okay, now I'd like to just go through some of the more important features of this modality, and I want to use the sort of the study or the cheat sheets with us. So what you really need to know with this is who can use it, when can they use it, when should people not use it, and what do you do to set it up. And so once you've done it a couple times, it's not very difficult at all. I did it in service the other day for about 11 people, and they all felt a lot more comfortable. So I think that there are going to be more and more people on the unit that are going to be comfortable with how to turn it on and how to check for the integrity. We've got a system built into place where Hector Cabo Gonzalez, who's right now is the respiratory technician, he will be coming up 3 days a week, Monday, Wednesdays, and Fridays. He is in the hospital from 8 o'clock in the morning till 1400, and he will be checking the lines, he'll be checking the tank levels, he will be checking supplies in terms of the corrugated tubing, the mask, etc. He will be checking that 3 times a week and recommending when we need to order more. So I think that's a really good safeguard right now. So if you have concerns or questions, you can always call him. Again, he is only here weekdays and not stats or weekends, between 8 and 1400. If there are concerns or questions at other times, the RT may be able to help you, they may not. It depends on what their workload is like, but that's why we have 2 units on the floor, and that's why there are 2 tanks on each. So if there's a problem with one tank, we're gonna switch over to the other tank, and I'm going to show you how to do that. Okay, so we've been through the tanks and everything else. I've talked about the roles of the staff in terms of the nurse or the midwife providing the care to the patient. We'll talk a little bit more about that in a few minutes. Indications for use, primarily it's labor analgesia during the first stage of labor. I have seen it used occasionally during second stage. It would be dependent on how the patient is doing and up to the practitioner. Definitely patients waiting for an epidural, it's a great bridging tool. So if they know that they've got something that'll help them while they're waiting for the anesthetist to come, that's often very, very helpful. We can also give it to patients having procedures done which may be painful, including external cephalic version, manual removal of the placenta, obviously if they don't have an epidural or a spinal in place, vaginal laceration repair, a removal of a cervical suture, and insertion of Foley balloon for cervical ripening. So the unit can go to triage, and it can be used in triage. You just have to make sure that you are setting up your scavenging system appropriately with your suction tubing, and the end of it going to a red topped container with the suction turned on to full. Let me just get rid of that for now. There's a lot of tubes hanging around here and things like that. Okay, now the contraindications, you know, there's relative contraindications and more absolute contraindications. And if you have any questions about patients' eligibility, I think it's always good to have a conversation with the healthcare provider. So the following first 3 might exclude a patient from being eligible, and a thorough risk assessment should be employed. So these are patients who've been given or those who take opioids, benzodiazepines, and other CNS depressants, because we're more concerned about respiratory depression and poor respiratory status. Patients with acute respiratory infections or respiratory disease, we talked a little bit about that before, and patients who've undergone jaw surgeries or facial injuries which prevent them from obtaining a good seal with the face mask. So that is really, really important, because one of the key features of this, and I am going to take the plastic bag off now so I can demonstrate properly, is that you do need to get a really good seal. Well, you can't hear me if I say it like that, but a really good seal, because the patient needs to inhale and exhale with a good seal, because this is the kind of gas where we're not going to be breathing it in and then exhaling into the environment. Inhale and exhale into the mask, okay? So it has to be tight. Can you hear me? It's not on, don't worry. Okay, and that's what they should be doing when they're breathing in the gas. The way this works is that it is it's a demand valve. So it's when the patient breathes in, the little valve in here opens so that the blended nitrous oxide and oxygen combination will go through to the mask. As soon as they stop breathing it in, the valve closes, and when they exhale, it goes down through the scavenging tubing, which is a good safeguard, because if they stop using it and they just leave the mask sort of like here, it's not going to be releasing nitrous oxide into the environment. Okay, so that is an important feature for you to know. So yes, so the integrity of the fit over the jaw, really, really important. Following, the next following, I think there's 9, or so say 11 situations where we'll exclude a patient from being eligible to use nitrous oxide gas. So here we're going to talk about the conditions that give us the potential to create space for the collection of gas. So that would be somebody with a recent pneumothorax, gastric bypass surgery, or an inner ear surgery. Somebody with documented pernicious anemia or vitamin B insufficiency. So I'm not sure what we use for our threshold for pernicious anemia, but if their hemoglobin maybe is less than 8, this is going to create more of a challenge to be able to metabolize the gas. increased intraocular pressure or previous eye surgery except for vision correction or LASIK. Okay, so that's fine, but if they've had other kinds of eye surgery, there's a potential for a space to be created. Abnormal fetal heart rate tracing, safety concerns regarding patient ability to self-administer and hold the face mask. So we cannot have family members or other people offering to hold the mask for them. Absolutely no. Acute drug or alcohol intoxication, impaired consciousness, hemodynamic instability, and impaired oxygenation with either one or both of the following. So this is when it kind of starts to look like they're not really in very good respiratory status, either a respiratory rate of less than 12 breaths per minute, or an O2 saturation of less than 95% on room air prior to administration of the gas. So for all of our patients that are going to be using the gas, there's a number of interventions that need to happen prior to use. So we have to determine patient appropriateness for nitrous oxide use and screen patient for contraindications. And we're very fortunate that Katie has added the nitrous oxide use to the admission order for laboring patients in FBC, so we don't have to get a specific order for it. We just need to decide whether we're going to activate it for those with obstetrical patients. Midwives obviously can order it and administer it. If the patient is under the care of the physician, we've got the order. We're going to obtain and document the patient's verbal consent. We're going to provide patient education for instructions to use, including possible side effects. And that is outlined in the power chart under the points for the education, and it's also in this document here. We'll go over it. We're going to check the equipment to ensure it's clean, ready for patient use, including adequate amounts of both oxygen and nitrous oxide gas. We're going to set up adult patient resuscitative equipment, including the oxygen and the suction. Now, you're going to be using the suction for this, but you need to have your yanker suction on standby. If the patient is requiring suction, you will have to take the nitrous oxide suction out, put your other suction in, and suction their mouths. In the beautiful world, there will be 2 different red canisters, so I am working on that. Perform initial assessment on the patient, including their vital signs with an O2 saturation, and ensure that all vital signs are within the normal range. Now let's talk a little bit about the levels. Actually, is there anything else I can talk about? Oh yeah, let me just go on a little bit while I'm sitting here, and then I'm going to move the iPad over to do a bit more showing you some levels. So set up your infant resuscitative equipment, including oxygen and suction. If you're using it during labor, performing fetal health surveillance either by intermittent auscultation or external fetal monitoring, depending on the patient condition and risk factors. So, with intermittent auscultation, the fetal heart should be classified as normal prior to the use of the nitrous oxide. If the external fetal monitoring has been indicated prior to the use of this, so this is not an indication for external fetal monitoring, okay, in itself. It is if the patient has already been on external fetal monitoring, or they're going on oxytocin or some other reason for external fetal monitoring, then you need to have a 20-minute tracing ahead of time that has to be classified as normal. Okay. All right, I'm going to stop right here, and I'm going to get the iPad and demonstrate a little bit differently. So that'll be in part 2.